So, hi, welcome everybody. I'm Dr. Horn with infectious disease. Today's topic, we're going to be talking about winter respiratory illnesses. So, we're going to be talking about influenza, RSV, and COVID-19. And these are good topics to discuss. This is a good time to discuss them. This isn't meant to be comprehensive, so this isn't going to be everything about the subject, but we're going to try to hit the high points, the things to remember when you're seeing these patients, and kind of the important stuff. But I hope you'll find it helpful. If you have any questions at all, you can always write it in the chat, and I'll try to get to all of your questions. And let's see. All right, so the current data. So as of November 8th, 2024, the amount of acute respiratory illnesses causing people to seek healthcare nationally is low. So we haven't really gotten into the season yet. All of this information is available through the CDC, and they have like a flu net. They have maps that you can see, and they keep track of it, and they update it pretty frequently. So you're able to see how things are going, and they'll have maps of where in the country and what strain. And COVID-19 activity is stable or declining in most areas, and minimal seasonal influenza activity is occurring nationally. Signs of increased RSV activity has been detected in the southern, southeastern, and mid-Atlantic United States, particularly in young children. And this is the map right now, and this is the map that gets updated. This is influenza-like activity, and they have it influenza-like activity level on the right side. And you can see right now it's all light green, and that's how it starts. It starts out minimal, and then it continues to increase. So if you're keeping track of these maps, right now it's just starting out. The influenza-like activity is what they track, and so that's when people are presenting, you don't always have influenza that's been identified yet, or you don't always have positive influenza um, uh, in the patients that you see because you don't test all people. So when there's high influenza activity, um, if you have a positive influenza, or sorry, if you have a negative influenza test when there's a lot of activity, it's probably a false negative, right? And then if there's really low activity to no activity and you have a positive influenza test, it's probably a false positive. So it's and not all people are tested. That's why they are following influenza-like activity. The uh, epidemiologic trends. So these are one of the things they follow, and they can see if it looks like it's increasing or decreasing or staying the same. And so this is one of the maps that they have, and they have it for influenza, and you can see it's growing in activity. And then they also have it for COVID. And here it's likely declining in most places, although it's likely growing in a couple places like Illinois, Arizona, and just a few places there. So we'll start with influenza. So the flu shot is the best way to prevent the flu, is the best thing we have. Studies show that getting vaccinated reduces the flu illness, reduces doctor visits, flu-related hospitalization, life-threatening flu episodes. It reduces death. So it's the best thing we have. And so sometimes you'll hear people say, like, oh, that it doesn't prevent the flu, and it reduces illnesses, and then if you do get the flu, it'll be not as bad as if you didn't get the shot. So it's the best thing we have. So I strongly recommend getting your flu shot, especially in children. So children who got a flu vaccine were 50% less likely to have a flu-related emergency department visit and 70% less likely to be hospitalized with flu illness or related complications compared with those that were not vaccinated. So I recommend everyone get vaccinated and get their kids vaccinated. All flu vaccines in the United States will be trivalent. beginning 2024 to 2025 flu season. So it's in this is A H1N1. So A is uh, the type of influenza. So influenza A H1N1, influenza A H3N2, um, and influenza B Victoria lineage virus. So in the past, they used to have this other one, influenza B Yamagata virus, but it's not going to be included in the future because it hasn't been detected since March 2020. So they're going to have a trivalent vaccines. And, when they pick out the strain and put the strain, um, it's essentially their best guess as to what's going to be affecting us here. Now, um, even if the guess isn't completely correct, so even if it's a different strain of the virus, the flu shot can still be helpful. There are large studies that are looking at when people get shots, and if someone consistently gets a shot every year for many years, in the future, if they get the flu, even if it's not a strain that they've seen before, even if it's not the exact same one, it's still helpful and it still helps them. So, um, it's encouraging, I think, to know that even if you're getting shots that are not exactly the type of flu that you are getting sick with, either now or in the future, getting shots consistently for the flu is actually very helpful. And so I think that's encouraging and um, a good way to think about it and put it rather than thinking that, oh, they're gonna get they're gonna get it wrong. Like if you hear the detractors, the people that say that getting the flu shot doesn't help, they might say things like, oh, that it, it they might not choose the right one. But even if they don't choose the right one, it's still helpful. So as far as isolation precautions for people with influenza, wear a face mask when entering a room of a patient with suspected or confirmed influenza. Um, and if they need movement, then you have the patient wear a face mask to try and prevent the spread of influenza within your facility. And high risk groups. So there's it's very important to recognize patients that are high risk because um, influenza doesn't affect us all in the same way, especially if a person is high risk. And it's important to take influenza seriously because people can get very sick and die, especially people that are in these high risk groups. So high risk patients developing influenza, you're thinking of children less than 5 years old, especially less than 2 years old. I think there's the first death from influenza this year was just recently in a child in an infant and adult adults 65 and older are also in the high risk group. Women who are pregnant or postpartum within 2 weeks after delivery also in the high risk group. American Indians and Alaska Natives, so they are disproportionately have bad outcomes. Extreme obesity and residents of nursing homes and chronic care facilities. So when considering when to treat someone for influenza, um, it should come into well, you should think about, is this person high risk or not high risk? And then also, even if they're not high risk, are they around people that are high risk? And we'll discuss this more in just a moment. When influenza is widespread, so influenza-like illness can be assumed to be influenza without testing. So if someone comes in with influenza-like illness and there's a lot of influenza in the community, you can assume that they have influenza. Patients can be diagnosed clinically, do not require testing or clinical management, including antiviral treatment decisions. So if you see them and you think that they have the flu, that's enough to decide to treat them. When prevalent in the community, a negative influenza test is likely a false negative. So if everyone has the flu and you test someone and you think they have the flu and it's negative, it's probably a false negative. And use droplet precautions, hand hygiene, and contact prophylaxis. And influenza testing. So clinicians should use a PCR or other molecular assays over rapid influenza tests to improve detection. So we've had cases where a patient has a rapid antigen and it's negative, and then they transfer facilities or we accept them. And then, it turns out that they actually do have influenza and that antigen, the rapid antigen was negative. So if it's possible to use a PCR, that's better. And clinicians should not use rapid tests in patients except when more sensitive molecular assays are not available or when there are high rates in the community. Then the antigen test would be okay to use. But follow-up testing with PCR or other molecular assays should be performed to confirm a negative rapid test result. So if you have a negative rapid test result, it may not be reliable. And so you may want to double check with a PCR if possible. And as far as treatment, so antiviral treatment is recommended as early as possible for any patient with confirmed or suspected influenza. So you want to start treatment right away. Patients of any age who are hospitalized with influenza, so that's if they're in the hospital, then treatment is indicated. And so if they're in the hospital, that means that they are could be very sick from influenza, or they're sick from something else, and then they're discovered to have influenza. But it's important to realize that this says patients of any age who are hospitalized with influenza. So you want to treat those patients. And it also doesn't have a timeline here. So because there's no timeline, even if they developed influenza or they were greater than 48 hours before coming into the hospital, if they're hospitalized, you would still treat them. So the next one is outpatients with severe, complicated, or progressive illness, and people that are higher risk for influenza complications. So here it says give influenza treatment even after 48 hours if they're hospitalized. So when the studies were done looking at the timeline for if they're presenting within the first 2 days and they were treated, then there was a benefit there. It prevented hospitalization, but if it's been longer than 2 days, then it may not prevent hospitalization in a patient that doesn't have any uh, severe, complicated, any underlying issues. But if they're hospitalized, then everyone should get treatment. And this is something that we have every year. We get questions on, there's a patient that was perhaps at a nursing home. They were discovered to have influenza, and it's been longer than 48 hours, or they're transferred to the hospital and it's been longer than 48 hours. What is the next step? And even if they're not hospitalized, if it's a very chronically sick person or they've got a lot of comorbidities, I would consider treating people and being kind of liberal with who gets treatment. We'll talk about nursing homes in just a minute, but if a patient's, I would have a very low threshold and say that I only really follow it's been longer than 48 hours not to treat in patients that are healthy, and I would discuss it with them. Who is at high risk for complications? So children younger than 2, adults older than 65 years old, pregnant women, and those within 2 weeks postpartum, chronic medical conditions, and immunocompromised patients. I wanted to stress all of that because it's important because sometimes people, will talk on the phone and they'll say they're not immunosuppressed, and then it turns out they're pregnant, and that's still something I would, you know, treat them very aggressively. Patients that are pregnant, just with infections in general, I try to be aggressive with treating. And consider antiviral treatment in those that are not high risk of complications with a documented or suspected influenza, irrespective of influenza vaccination history. So sometimes people will say, well, they've been vaccinated or they haven't been vaccinated. Should I like not give them Tamiflu, also Tamiflu, because they've been vaccinated in the past? But I think that's something to think about. But I think it's important to be, I kind of want to treat as many people as I can, also to stop the spread. So outpatients with an illness onset less than 2 days before presentation. Symptomatic outpatients who are household contacts of people who are at high risk of developing complications. So if there's a person that it presents with influenza and they take care of someone in their house that is severely immunocompromised, it'd be important to treat that person to prevent the spread to the person that they're caring for. Symptomatic healthcare providers who care for patients who are at high risk of developing complications from influenza, particularly those that are severely immunocompromised. So if they have household contacts that are severely immunocompromised, or if they're healthcare providers, you know, we want to do our best to try and prevent the spread. And then as far as influenza treatment, so there's oseltamivir, which is Tamiflu. That's usually what we're treating with and what we're talking about when we're discussing treatment. Zanamivir is inhaled, and if a patient has bronchospasm, um, well, it can induce bronchospasm, and it's contraindicated in patients that have asthma or COPD patients. So I try to stick with oseltamivir as much as possible. Um, Peramivir is IV only, so if a patient is having vomiting or unable to take PO for whatever reason, if you're able to give them IV peramivir, that's an option. And then baloxavir is oral. It was approved in 2018 and for influenza A and B, and it's a single dose by mouth, and it can reduce the symptoms from about a day. Now, in hospitalized patients with suspected or confirmed influenza, initiation of antiviral treatment with oseltamivir is recommended as soon as possible. So, as far as which drug to choose, this is what going from by the CDC, it was saying oseltamivir, and it only really mentioned the others for outpatients. So, outpatients with complications or progressive disease and suspected or confirmed influenza, initiation of antiviral treatment with oral oseltamivir, and outpatients with suspected or confirmed uncomplicated influenza, then that's when it mentions oseltamivir, inhaled zanamivir, intravenous peramivir, or oral baloxavir. So, um, if possible, I give oseltamivir, Tamiflu, and then I only consider something else if we're unable to give oseltamivir. And as far as complications, so when we're talking about complications, uh, you know, secondary bacterial infection. So this is the most important complication. So patients that die from influenza, um, a vast a majority of them, or a very high percentage of them, actually die from a bacterial infection. So they have influenza, and then influenza essentially weakens their immune system, and then they get an overlying bacterial infection such as strep pneumo, Staph aureus, um, the uh, other types of strep also can can um, can be present, but strep pneumo is the most important thing to treat when you're deciding which antibiotic to give for community-acquired pneumonia. However, in influenza, if a person has an overlying bacterial infection, Staph aureus moves way up in the line. There's Staph aureus MSSA and MRSA. So after influenza or during an influenza, if a patient has a bacterial infection or you want to cover for bacterial infections, it's important to also cover for MRSA. So the classic presentation for a patient that had influenza and then they develop a secondary bacterial infection, a secondary bacterial pneumonia, would be that the patient is diagnosed with influenza and then they're starting to improve. They're starting to feel better. And then all of a sudden they decompensate and they get worse very quickly. So in those cases, especially, it's important to think about, did they have influenza? And then the worsening is a bacterial infection. So sometimes people might say, oh, it's just they have influenza. And then uh, not think about any other types of um, conditions that the patient would have because they anchor on influenza. So there's a type of bias that's anchoring bias, and it's when you anchor on something and then you um, don't think about anything else. So it can be something that, you know, essentially you stop looking for other causes of their symptoms. Um, so instead of just saying, oh, they have influenza and then disregarding their symptoms from then on, it's important to say, oh, they could have, uh, you know, a worsening of their severity due to a bacterial infection. Now, as far as influenza imaging, so this is an example of a chest X-ray. This is that you would see with influenza. So patchy bilateral infiltrates and airspace opacification predominantly um, in the mid and lower lung zones. So here you can see it's patchy. It's kind of all over the place. It's not just in one location, as opposed to a bacterial consolidation that would typically be in one lobe and very dense, just all in one area. So this is kind of all over. So here again we have extensive patchy bilateral ground glass opacities, and that this is CT of the chest with influenza. So it's you can see it's kind of patchy. It's in multiple locations, and it's not very dense as you'd expect a consolidation. So here would be a secondary bacterial pneumonia. This is a lobar consolidation. So this is um, would be a classic classic pneumonia uh, due to a bacterial cause. Now, what antibiotic should I give if I suspect a secondary bacterial infection associated with influenza? So the thing to think about here is what bacteria do I want to cover? So I want to cover strep pneumoniae. I want to cover Staph aureus, MSSA, and MRSA. So then what would I give to cover those? So ceftriaxone would cover strep pneumo very well, and it would cover strep in general very well. I wouldn't give ceftriaxone for MSSA, so I don't give ceftriaxone for Staph aureus because it can develop resistance while you're treating it. But ceftriaxone plus doxycycline would be a good combination to cover strep pneumo very well with a ceftriaxone, and then it would also cover MSSA and MRSA with a doxycycline. So that would be a good combination. Levofloxacin. So levofloxacin is a respiratory fluoroquinolone, which means it covers strep very well. It covers a little bit of staph, but it also covers strep very well, as opposed to something like ciprofloxacin. Ciprofloxacin is not a respiratory fluoroquinolone, and you wouldn't want to give cipro for a pneumonia. But here you're giving levofloxacin plus doxycycline to cover MRSA. And then outpatient, augmentin. So augmentin would cover the strep. Doxycycline would cover the MRSA. And you can give the doxycycline to cover MRSA and know that it covers very well. In Nebraska, doxycycline covers MRSA, roughly 95% of the time. So it's very good at covering MRSA. Now, even in strep pneumo, if you had a patient that was very sick with strep pneumo, and we discussed this in our community-acquired pneumonia discussions, you would be giving ceftriaxone plus azithromycin. And the azithromycin and the ceftriaxone together is essentially to double cover strep pneumo. So they both cover strep pneumo, and patients that get ceftriaxone plus azithromycin with strep pneumoniae, bacteremia, or in cases where strep pneumonia has been identified, they do better with two antibiotics. So they do better with ceftriaxone plus azithro. So that's why the recommendation is there to give ceftriaxone and azithromycin in community-acquired pneumonia because it's double covering the most common cause of community-acquired pneumonia, which is strep pneumoniae. But in those studies, when they looked at that, they also said that two antibiotics for strep pneumoniae, the patients did better in the population that was extremely sick. So in um, the severe category. So when they looked at two antibiotics, they also looked at they did several antibiotics, and it didn't matter if it was ceftriaxone plus azithro or ceftriaxone plus levofloxacin. If it were two antibiotics, the patients did better, which is not always what we see, and it's not always what we recommend. But in those cases, that's why we give ceftriaxone plus azithromycin. Now, another thing that you could do if you wanted to cover strep plus MRSA very well, for the strep, you could also give an oral third generation cephalosporin such as ceftonir or cefpodoxime. Cefpodoxime has better bioavailability and gets in very well than ceftonir. Now, when you're giving something like Tamiflu for chemoprophylaxis, this is another question that we get. So if there's a patient in a nursing home and you want to stop the spread within the nursing home. So oseltamivir, it's 70 to 90% effective in preventing influenza against susceptible influenza viruses. So recommended duration is 10 days. So control of outbreaks. So if you have a patient that was exposed, let's say you have a patient that has severe underlying lung issues and they were exposed to someone with influenza, they call and they say, I was just with my friend and my friend just tested positive for influenza. It'd be okay to give them oseltamivir for 10 days to try and prevent them from getting the flu. So for control of outbreaks in institutional settings like hospitals and nursing homes, you can give Tamiflu for a minimum of 2 weeks and continuing up to 1 week after the last known case was identified. So you'd be giving this to try and prevent it within the facility. And it's recommended for all the residents, including those that have received their flu shot. So you'd be giving it to all the residents, trying to really stop the spread within the facility. RSV, so RSV vaccine and monoclonal antibodies. So the RSV recommendation for vaccines for adults 60 and over is rather recent. Adults 60 years of age and older may receive a single dose of an RSV vaccine. And CDC recommends an RSV vaccine for all adults aged 75 years and older, and for adults 60 to 74 who are at increased risk. So this is what the CDC says. So there's it's important to discuss with your patients and uh, and recommend the vaccine. Infants and young children. So the recommendation is to give. This should actually be in the other order. Pregnant people. It's you would be giving the vaccine to the pregnant woman and 32 through 36 weeks of pregnancy and during September through January. So you're going to try to vaccinate the mother. So her antibodies will also go to the baby, and then the baby will be protected. If the pregnant woman has not been vaccinated, or if you have a baby and the mother was not vaccinated, then that's when you would be discussing giving the monoclonal antibody to the baby to try and protect the baby. So here is another way of looking at it. This is adults 60 and over. This is the RSV vaccine, and you can give it to adults that are 60 to 64 who are at increased risk of severe RSV, and everyone ages 75 and older. And as far as babies, RSV antibody, uh, this is given to the baby, to infants whose mother did not receive the RSV vaccine during pregnancy, and some children ages 8 to 19 months who are increased risk. So if the mother was vaccinated, then the baby will have those antibodies. But if the mother was not vaccinated, then you can consider giving this to the baby to protect the baby, October through March. And then as far as babies, all pregnant people during weeks 32 to 36 of their pregnancy um, are recommended to have the RSV vaccine to protect their baby. And as far as which vaccines are available, there are 3 vaccines there's GlaxoSmithKline, there's Pfizer and Moderna, and RSV vaccines that are approved. So um, there were, I believe, two approved a year ago, and then one approved this year. I think Moderna's was just approved this year, but um, they actually do a very effective job and are excellent. So I would recommend talking to your patients and trying to get people vaccinated to help them to help prevent RSV and prevent them from getting severe RSV. And as far as babies, so we recommended, or we just discussed giving RSV vaccination during pregnancy. Um, and it's given 32 through 36 weeks, and it can reduce a baby's risk of being hospitalized from RSV by 57% in the first 6 months after birth. So this is something that is very effective, and we want to do everything we can to try and prevent RSV um, and this is Nirsevimab reduces the risk of severe RSV disease by about 80%. So this is directly giving the baby the RSV monoclonal antibody to protect them from RSV. And COVID-19. So COVID-19 vaccines, it's important to stay up to date and get your 2024-2025 COVID-19 vaccine because it will help you because your vaccine that you've gotten in the past, the efficacy decreases over time. And the newest vaccines are good and they're the best protection from the currently circulating strains. So it's especially important if you've never received a vaccine, if you're 65 years and older or at high risk of COVID-19, living in a long-term care facility or pregnant or breastfeeding. And who needs a COVID-19 vaccine? So the recommendation is for everyone ages 6 months and older to get the COVID-19 vaccine. And this includes people that have received a COVID-19 vaccine before and people who have had COVID-19. So it's because when you get the vaccine, after getting the vaccine, your antibodies increase, and when you respond to it, and you're most protected, recently after getting it, as opposed to waiting because the efficacy wanes and goes down. Now, there are new COVID-19 vaccine recommendations. There's uh, ACIP makes the recommendations, and the CDC also makes recommendations, and and some of those have just changed in September and then also in October. So in patients that are not immunosuppressed, so if you're up to date when you are up to date when you have received a COVID shot. So you can either get one dose of Moderna or one dose of Pfizer, um, or one dose of Novavax. And there are some uh, stipulations like Novavax vaccine, unless you're receiving COVID-19 vaccine for the very first time. If you have never received any COVID-19 vaccine and you choose to get Novavax, you need 2 doses to be up to date. So if you get Novavax and it's your first time, you get 2, and the others you just get 1. And this is if you are not immunosuppressed. And then, oh, and this is one of the changes that I said was just recent. This is October 23. The CDC director, um, and this is endorsed the CDC, and this is ACIP recommendation for people 65 years and older who are moderately or severely immunocompromised to get a second dose after their first dose. So if you're um, 65 years and older, um, you can get a second dose. So in non-immunosuppressed people, you would just get 1. If you're immunosuppressed or older, you could get 2. ACIP also makes additional recommendations for moderately or severely immunocompromised. So people that are 6 months older than 6 months, moderately or severely immunocompromised, should receive at least one dose of the COVID shot from this year. Depending on the vaccine history, additional vaccines may be recommended. So if they're unvaccinated and they're 6 months to 11 years, moderately or severely immunocompromised, so they say you should get, so that this first bullet is you should, they should get at least one. And that's, they say you should get at least one. And then if you're immunocompromised, you might get more. And it's unvaccinated people, 6 months to 11 years old, moderately or severe immunocompromised, recommended to receive an additional 3-dose vaccination series, all with the same manufacturer. So they get 3 doses. And then unvaccinated people that are 12 or older, moderately or severely immunocompromised, should complete an initial vaccination series with either 3 doses of this year's COVID-19 vaccine from the same manufacturer or 2 doses of Novavax COVID-19 vaccine. And previously unvaccinated, you'd get 2 doses of the 2025 COVID-19 vaccine. So this is, and these recommendations, um, the CDC and the ACIP all, each group makes their own recommendations. And as far as treatment, I'm just going to mention treatment and just have this here, in case I think we're all familiar with the treatment of COVID, but for people that are not requiring hospitalization or supplemental oxygen, so if they are in the hospital but they're not getting supplemental oxygen, they'd be treated as an outpatient. So preferred therapies, they can get Paxlovid or remdesivir. And then if they're in the hospital and they're requiring oxygen, that's when you would add steroids. Well, this is also non-hospitalized patients, and then we have hospitalized patients. And I'm not going to go through this whole thing. I think we're familiar with it, but I just wanted to leave it here for the most up-to-date recommendations that are available. But if they're requiring supplemental oxygen, that's when you would add dexamethasone. And I'll leave this here for people if anyone's interested, and a little bit more on medications. All right. Thank you, everybody, for joining. If you have any questions about this, you can always email me. I'm always available, or call me, and we can talk about it. And if there are any future topics that you're interested in, if you want me to go over anything that we haven't discussed in a while or anything new that I have never discussed, please send an email and we'll be sure to add it to a future webinar. All right. Thank you, everybody.